It's 8 o'clock, and good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is about menopause and beyond. We are happy to have Dr. Nitu Bajekal, Senior Consultant Obstetrician and Gynecologist, and a Lifestyle Medicine Physician in London. Incidentally, Nivedita is the batchmate of Radhakrishna, me, Ravi Shankar, and many others who have logged in today. She did her MBBS from JIPMA Pondicherry and MD Obstetrics and Gynecology and DNB from All India Institute of Medical Sciences with a gold medal. She's also a diplomate of the International Board of Lifestyle Medicine. Her special interests include lifestyle medicine, menopause, PCOS, endometriosis, and a few other things. She's on menopause, PCOS, and women's health issues, lecturing extensively all over the world. Her publications include books, the latest one being Finding Me in Menopause, Living PCOS Free, book chapters, and health modules for courses. She's passionate about educating women, providing reliable medical and lifestyle information for the general public, doctors, workplaces, and schools, for which she runs an exhaustive website and is very active on social media. Runs a voluntary service set up to educate, energize, and empower schoolgirls and women to make lifestyle choices to help improve their own and their family's health. We're very happy that Dr. Nitu Bajekal immediately accepted our invitation to speak on this topic for Marvelous Medicine.
Thank you, Vidya. Long introduction, which is probably not deserved, but let me see if I can share my screen.
Just a minute. Moderating the session will be Dr. Meera Raghavan. She's a consultant urogynecologist and robotic surgeon at Apollo Hospitals, Chennai. Dr. Meera did her MBBS from Madras Medical College and MD Obstetrics and Gynecology from Postgraduate Institute of Chandigarh, both with gold medals. She's the secretary, Chennai Menopause Society, and executive committee member of OGSI, core committee member of Urogynec subcommittee of OGSI, among several other responsibilities. She's the director of Apollo Simulation Critical Obstetrics Team Training, and that's how I met her during a faculty development program. She's also an MRCOG trainer and examiner. She has several publications in national and international journals to her credit. Thank you, Dr. Meera, for taking time off, which is normally your busy OPD time, I understand.
Thank you, Dr. Vidya. Thanks for the opportunity.
Co-moderating the session will be Dr. Shobana Mahadevan, consultant obstetric gynecology at Sitapati Clinic in Apollo Hospitals, Chennai. Shobana did her MBBS from Madras Medical College and is a gold medalist in MD Obstetric Gynecology from Stanley Medical College. She's also a member of the Royal College of Obstetrics and Gynecology in UK. Shobana's special interests include management of high-risk pregnancy, sexual and reproductive medicine. She's actively involved in teaching programs and is also an MRCOG trainer and examiner. She has been an invited speaker at several national and international conferences. Thank you, Shobana, for immediately accepting my request to be a moderator for this session. Over to you, Nitu alias Nivedita.
Thank you. Thank you. I'm going to try, I may have to skip a few slides because I've just realized that the audience may already know a lot of the stuff, but let me just go to share. So just before I actually dive into the lifestyle aspects of menopause and probably just touch a little bit about hormone replacement, as there's still so much of myth every time I come to India and find that a lot of women are scared of hormone replacement and are also unclear about the lifestyle choices. I'm going to just try and go through some of a few statistics and how difficult it has been for women to be heard. But the truth is that a quarter of the world's population will experience menopause by 2030, and most of us will still be at work, with 1 in 4 experiencing severe enough symptoms that may need us to leave the job. So this is not to be taken lightly because it affects the person itself, the family, as well as society at large. And many factors, including social factors, can affect how one experiences menopause, In the West, people are afraid of getting old, so they often look at menopause with trepidation, while in certain cultures, people actually have more power once they've stopped their periods. So those things also influence, and it also matters as to whether you can talk about your symptoms freely. And so when we often hear about our grandmothers and mothers sailing through menopause, it's because they probably never had a platform to talk about their menopause experiences. And unsurprisingly, even female doctors really have struggled to be heard, saying that 40% said the impact of menopause was significant enough, but they found that most of the time, when the BMA survey asked them the questions, they were not really heard. And women, this was echoed in the US and all over the world, where women often feel dismissed. And Channel 4 basically came out with a wonderful report where they showed that 8 out of 10 women felt that their employer hadn't shared any information about menopause, perimenopause, and only 4 in 10 were offered hormone replacement in a timely fashion and weren't judged for it and were actually offered it. So these are all very important statistics in countries where there's supposed to be, equality and liberation, and it's not necessarily always true. So here is a bit where you may find it very basic, but I do sometimes feel that one has to explain these before we actually go into the details. So this is a woman who's 46, and she says that her periods are coming more frequently. She's having some panic attacks, some hot flushes, and also having reduced sex drive. Now, this is usually what is seen in perimenopause. Perimenopause is the time leading up to the periods completely stopping. And the range can be anywhere between 2 to 8 years. So the average age of menopause tends to be about 51 years all around the world. But in India, actually, it is between 45 and 47. And so if you imagine that perimenopause and the symptoms of the hot flushes and period issues and heavy periods and skipping periods and lowered libido starts anywhere up to 8 years before, women may be at the time when they have not yet actually started building their family. They may be 35, 36, 38, depending upon when you're destined to stop your period. So, and you might be at the peak of your career trying to apply for jobs and climb the career ladder when you're then having all these hormonal fluctuations, menstrual irregularities, all the symptoms that are associated with menopause can also be there along with period issues. And interestingly, bone loss and lipid changes can start at this stage. We know that bone loss starts in as one hits our early 30s, but this can get accelerated as we approach menopause. So perimenopause has not really been talked about much before. The average age tends to be 47. It tends to be gradual unless a gynecologist like me does a total laparoscopic hysterectomy, or somebody has cancer and they're on chemotherapy. That can be drastic, and those symptoms actually can be much worse than the gradual decline in hormones. And basically, the ovaries start to fail. And so here is the little menstrual cycle, and hormones, which are chemical messengers, are working from the pituitary gland and the hypothalamus all the way down to the gonads and actually deciding how much of estrogen, progesterone, and testosterone is produced. In fact, a woman has 4 times more testosterone in her reproductive life than estrogen. And so as these levels drop, you can imagine why there is bone loss, why there are hot flushes, and various other symptoms. So perimenopause is 2 to 8 years leading up to the period, while menopause is a retrospective diagnosis. It basically means that there are no periods for 12 months, and the range is anywhere between 45 to 55. Now, we know that North Indian women tend to have menopause around 46, 47. South Indian women between 45 and 46. Of course, these are just statistics, doesn't mean that everybody will have that, but compared to the rest of the world, women in India and the African community tend to have earlier menopause. And so it's very mindful for employers and all to be aware of this. And we tend to divide menopause into two halves for medical purposes. Under 6 years of stopping your period, so 12 months of no periods, The first 6 years are usually the acute vasomotor symptoms, and the next 6 years and for the rest of one's life, because you're always menopausal, you never finish menopause. So those are the times when you have cardiac issues, dementia, arthritis, joint issues, bone health issues. And so it is important to address these and not just focus on the vasomotor symptoms. And the reason menopause occurs, and it occurs only in a few species, orca whales and the narwhal whales and things. But generally speaking, what happens is we are born with a number of eggs. So at 20 weeks of gestation, we have a couple of million eggs in our ovaries. By the time you're born, a female fetus is born, she has about 1 million eggs, and then over time, by puberty, a few 100,000 are there. And by the time she's 40, those have gone down to 100,000. And by the time menopause hits, then the number of eggs tends to drop below 1,000. That seems to be the critical number which is needed for estrogen levels to keep stimulating the pituitary gland. And so in response, the FSH and LH start rising, and that's one of the hallmarks of menopause, where follicular stimulating hormone levels tend to rise, because it's trying to get the ovaries to wake up. There are several predictors, when your mother stopped her periods, what race you come from. So Japanese women have later menopause, South Asian women have earlier menopause. Smoking, night shifts, diets, these things all can actually affect the age of menopause, even if it may be, some of these might be just by a few months or sometimes by a year. But it's important to know that these can be affected. So as the estrogen levels drop, the symptoms start, and there are, about 60 symptoms described. I've just described about 34 of them. But the common vasomotor symptoms tend to be hot flashes and night sweats, and women will often say brain fog and reduced sex drive and painful sex. Sleep disturbances are very common, and hormonal health can really be affected. But women will often also notice stress and depression and panic attacks. And then as they get older, they may notice bowel symptoms, urinary symptoms, vaginal dryness, cystitis, and increased frequency. But I have a lot of patients, women who will say that they have a burning tongue, or they have a crawling sensation under their skin called formication. But I also reassure my patients that they may not have any of these symptoms, or they may have a few of them. I've never seen a woman have all the symptoms, and that's important. And weight gain and things can be an issue, so I do spend time on my website and in my book to try and explain the background as to why weight increases. Of course, increasing age increases weight both for men and women. And then there can be other more distressing symptoms like scalp hair loss or excessive facial hair, and the longer term issues of balance and osteoarthritis and skin changes and bone loss. So it's important to be aware of these symptoms, because people often will say, but I've finished with the menopause, I don't need to know anymore. And that's actually wrong. All of us need to know, whether you're a cardiologist, whether you're an orthopedic surgeon, whether you're a physician or a primary care doctor, you need to know about menopause, because when women come to you, their symptoms may not automatically point to an effect of menopause, but we should be aware of it. Now, menopause, of course, can be many types of menopause. And so you can have medical menopause from chemotherapy, as I said, and radiotherapy, surgical menopause when you have your ovaries removed, if somebody has severe endometriosis or cancer. It could be premature ovarian insufficiency when one's period stopped before the age of 40. I myself, my period stopped at the age of 38, and unfortunately my primary care doctor refused to give me HRT in the mistaken belief that HRT was dangerous, when it's actually one of the safest medications around. So I actually missed out on it, and I do wish that because of the WHI study and the Million Women study that came out from US and UK, suggesting that women were at an increased risk of cancer, which was not really the case. And we'll go into that maybe in the Q&A session if somebody wants to understand it a bit more. So hot flashes tend to be one of the most commonly talked about symptoms. We are not entirely sure why they occur, but it may be because of the estrogen levels dropping in all tissues, including the brain. It could also be that the thermoregulatory zone in the hypothalamus is so sensitive to tiny switches of temperature that one ends up having this intense sensation all over the body, and it can be anywhere from a few seconds to up to 2 to 3 minutes, and it can occur to one a day to actually I have patients that can have several hundred a day. but it is important to keep other conditions and other medications in one's mind. And I've only brought up the kisspeptin and neurokinin B because there are drugs, the NCAND receptor antagonist drugs that are being brought in, Vioza and things, which are being brought in for people who can't take HRT but who are struggling with hot flashes, and clonidine and other drugs are not really working for them. So we are having some research, but not enough. How does one diagnose? And this is really a bugbear of mine. Women really don't need blood tests, hormonal blood tests, to diagnose menopause if they're above the age of 45. It's a clinical diagnosis. What's much more important is that we spend time looking at lipid profile, blood sugar levels, thyroid, full blood count, vitamin D levels. These are more important blood tests if you have a budget in a hospital, rather than doing FSH and estrogen to confirm menopause when somebody's not had their periods for 12 months. However, if somebody's period stops under the age of 45, and that happens to about 12 women out of 100, and that could be also include, and these don't really include those women who've had a hysterectomy. So we have a big chunk of women who stop their periods between 40 and 45. They do need tests after you've ruled out pregnancy. And under 40, they need to see a specialist who deals with POI. And it used to be known as premature ovarian failure, premature menopause. These are not good terms. There is nothing wrong with the woman. Their ovaries have not failed them. They have not failed. So the better term is to use the word premature ovarian insufficiency. That's a whole separate talk on itself, but it needs tests and specialist input. And cardiovascular and bone health are particular concerns for these early menopause group and the POI group. So we now we'll try and look at the lifestyle aspects of it. And this is where all men in the audience should sit up and take note, because everything that I say for menopause will ultimately also work to reduce prostate cancer, to reduce all the lifestyle conditions such as high blood pressure, diabetes. And so it's not as if there's a separate diet to look younger, a separate diet or lifestyle to prevent cancer or to manage menopause. And I just want that to be quite an important takeaway from this talk today. So Usha is in her perimenopause. She's having periods still, so her periods haven't stopped. She's struggling a bit with her weight. She's been told by one of the doctors that because her sister and aunt have breast cancer, she should avoid HRT, and that's not true. She can actually choose HRT, and this is the best age group around your perimenopause, and early menopause is when a hormone replacement tends to have the most impact for brain health, heart health, and bone health. But this lady wants to avoid HRT and wants to bring in lifestyle changes. And diet and lifestyle changes should come in whether you use HRT or not. And that is the premise of my book, Finding Me in Menopause, because I want people to realize that the patient is in the center of this. You decide whether you want both or you want one or the other. But really, it is important that you encourage our patients to try and bring in lifestyle changes all the way through from birth to death, because we know that it can make a big impact. Now, lifestyle medicine is not functional medicine, it's not Ayurvedic medicine, it's not homeopathic medicine, it's not acupuncture or any of those. It may use some of those principles, but basically it is a board certified exam. It's the American College of Lifestyle Medicine is very clear with this definition, and it involves the use of evidence-based, research-oriented scientific trials and studies that show that lifestyle therapeutic approaches can actually help to treat, prevent, and sometimes reverse lifestyle related chronic disease. And while menopause is not a disease, I want people to understand that this could be high blood pressure, this could be prostate cancer, breast cancer, it could be diabetes, it could be a number of osteoporosis. These are all situations where lifestyle medicine can play a big role, but it's not exclusive. It runs alongside Western medicine. It's not one or the other, but the difference between conventional Western medicine is we, the doctors, are in the driving seat, while with lifestyle medicine, self-care and self-management, nobody's watching you whether you eat that cake or whether you don't walk or whether you don't lift those weights. You decide how much you want to push yourself. So self-care and self-management is key. So, how do we apply these 6 pillars of the American College of Lifestyle Medicine to perimenopause and menopause? So, there are 6 pillars, and I'm going to try and go through this. And Vidya, please tell me when I'm coming out of time because obviously there are things that I don't need to talk about. It's basically the first is nutrition, and we're trying to eat plant forward. We're trying to eat more unprocessed whole foods. The second lifestyle pillar is moving our body. It doesn't mean going to the gym. It's Third pillar involves looking at one's sleep because sleep, for example, is probably one of the most important lifestyle pillars because we know that sleep is often used as a form of torture, sleep deprivation. So we know that if you don't focus on sleep, you will pay the price. I certainly am one who always was of the belief that I'll sleep when I'm dead. And I used to ask my trainees, tell them, why do you sleep more than 3 or 4 hours? I'm managing. And actually, that's one of the worst advice I ever gave my trainees. So restorative sleep is so important because it helps to manage stress. And the fifth lifestyle pillar is avoiding risky substances. And I'll go into all these and having a positive social network where you have friends and family that lift you up and you have purpose in life rather than have surrounding yourself by people who actually drag you down. So, why is it so important about diet? But we know that now 60% of the diet in urban populations tends to be ultra processed foods and drinks, and consumers are left confused. We know that 1 in 4 deaths are because of an unhealthy diet, with 11 million deaths according to the Global Burden of Lifestyle of Disease study, which looked at 175 countries. But what people say is that the information that is there in the newspapers on TV is leaves them confused. And this is a deliberate marketing ploy by junk food industry, by pharmaceutical industries. These things tend to confuse people. And as a result, what tends to happen is they start doubting their choices and then go back to eating their samosas and their biscuits because they are absolutely confused as to what is healthy. 1 minute something is healthy, next minute it's not. And as a result, we now face a pandemic of obesity and being overweight, with diet being a big factor, but also our lifestyle has become sedentary. We don't tend to walk anywhere. We tend to have lots of help at home in urban city populations, but also we tend to have lots of gadgets, and stress, alcohol, and socioeconomic factors also play a role. And once we start having increased body weight, it has an impact on every single aspect that we know of. All the chronic illnesses, type 2 diabetes, menopause is second to possibly smoking. So yes, after smoking, being a healthy weight is the most important thing one can do to prevent cancer, because cancer risks, dementia risks, all these tend to increase when we carry excess weight. But it doesn't have to be so. And we know that from the 5 blue zones, which are in Okinawa, in Sardinia, in Nicoya, and even in California in the US. And the beauty about this group is that they tend to move their body, they tend to have a community, they don't tend to abuse risky substances, but also they tend to have a huge chunk of their diet. 80 to 95% of their calories come from plants. For example, Okinawa is the purple sweet potato, is sweet corn in Costa Rica, it's pasta in Italy. Things like these. In Greece, you have lots of beans. So beans tend to be eaten 2 or 3 times a day in these diets. And so we do have a lot to learn from these blue zones that Dan Buettner has talked extensively about. And there's a very good Netflix serial, I think, How to Live to Be 100, which I would recommend that you see. And so this is me in Japan, and I tell you, I had the most wonderful plant-based food throughout, considering everybody said, oh, you won't be able to be vegan in Japan. I was, and I had the most delicious meals. But proper nutrition and eating 80% to fullness is probably the key to unlocking our body's potential. So, what food should we be focusing on in that first lifestyle pillar if you're trying to reduce menopausal symptoms of hot flashes, build your bones? You want to eat foods that are rich in fiber. Fiber is not present in any animal foods, and foods that contain fiber are fruit, vegetables, whole grains. The more fruit you eat, the lower the risk of getting diabetes. And the more fruit you eat, if you have diabetes, the lower the risk of the three top complications: blindness, kidney disease, and amputations. So we want to increase fruit, add fruit, but not fruit juices unless you're on holiday. You want to bring lots of vegetables, especially the artery dilating, ovary rejuvenating green leafy vegetables. You want to eat whole grains, red rice, brown rice, millet, amaranth, all these quinoa, whatever whole grains you can get, you want to bring them into your diet. Lots of potatoes and sweet potatoes, ideally with the skin. You don't want to fry them, you want to boil them, you want to put them in the fridge, take them out, the resistant starch increases. And so that's a great way of bringing your blood sugars down while eating very healthy fiber rich foods. Bringing in beans and lentils and peas and soya. Soya is so important that it has a whole separate section, even though it's a bean. And adding herbs and spices. No dish of yours should be eaten without having either coriander leaves or basil or cinnamon, some turmeric. These are really important for extending one's longevity and reducing cancer risk. Mushrooms, even a small button mushroom a day, cooked, not raw, you shouldn't be eating mushrooms raw, can reduce the risk of breast cancer by eating. Very good studies from China have shown that eating a tiny piece of a tiny mushroom a day is actually good enough to reduce the risk. So of course it's a cumulative thing. You can't be drinking lots of alcohol and eating a mushroom, but it's important that you actually try and be mindful when you put things on your plate. Seeds and nuts, a handful of seeds and nuts have been known to stabilize weight and also have lots of omega-3s and different nutrients. What are the foods you want to reduce? Really, the Coca-Colas, the sugar-sweetened drinks, the Fantas, the fruit juices, the white rice, the white flours, the cakes, the biscuits, the ultra-processed foods, bacon, processed meats, animal foods, dairy, ghee. These are things that really should be very rarely eaten in your diet. And you want to keep salt, oil, and sugar. While they are not dangerous, what you want to do is use them as flavoring. So try and learn to cook without salt, without oil, and then you can add your extra virgin oil on top of your salad, or you can squirt salt onto your food. But bring in things like anardana powder and amchur powder and so mango. Dried mango powder, also lemon and lime, all these lots of herbs. These help to reduce the amount of salt and oil and sugar that you need in your food, and you'll be surprised how within a few weeks you can change your palate. And why should we be eating like that, especially in menopause and for all chronic illnesses? Because it reduces inflammation. Inflammation is the building block for all these chronic diseases. So by reducing inflammation, you can actually help to make all these common problems that occur in menopause, type 2 diabetes and certain cancers, as well as heart disease, much lower. It helps to regulate blood sugar. It helps you to lose weight without having to try. Why? Because all these foods that you see are calorie light but nutrient dense. You want these foods to help to maintain a healthy gut. People often take probiotics. What are probiotics? Probiotics are actually bacteria. And so you already have those good bacteria. They just are hungry for the prebiotics. And prebiotics come from the fruits and the vegetables and the potatoes and the nuts and the seeds. So you want to eat a lot of prebiotics so that you have good probiotics, especially bacteria that are known as estrobolome, that synthesize the excess estrogen and throw it out of your system. So you're lowering the risk of breast cancer, ovarian cancer, and prostate cancer. And it also helps to improve immunity. So we know that there are so many benefits, and there are particular benefits in perimenopause and menopause, and there are many very good studies that show that the more whole plant foods you eat, the lower are the menopausal symptoms, the lower is the high blood pressure, the lower are the vasomotor symptoms. When you bring in soya into your diet, that brings even much more of an impact on your menopausal symptoms. The more vegetables and fruits we eat, studies have shown. I have lots of references on my websites as well as on my publisher's website. So anybody who's interested, I put a few here. But the more sweets and liquid oils and solid fats and the snacks that we eat, they tend to worsen our menopausal symptoms. While you bring in more fruits and vegetables, you will feel much more energetic. And when you're getting protein, because protein is really important for all of us in this audience, because as we age, our muscle mass reduces. Sarcopenia is a real issue. And so we need to use protein, but protein does not have to come from animal sources. So you need to work out where the protein is coming from. So vegetables, nuts, peanut butter, these are things that are important, while you want to reduce saturated fat that is found in meat and chicken and things like that. So as we move on, I have to talk about soya because both in the plant-based community as well as in the medical community and in the general population, they are very scared of soya. But soya is a bean. It's in fact a bean that's been around for 5,000 years. And it's not unique because the same isoflavones or the plant estrogens that you find, which have got similar effects to estrogen, promoting the growth in some tissues and blocking the effect of estrogen in others, is found in chickpeas, in beans, in all fruits, in whole cereals, in flaxseed, in cereal bran. So it's not as if these are unique, but the beauty about soybeans is it has the best proportion of protein, similar to egg white. In fact, tofu has more protein than an egg. So once you understand that these are products from a bean, you should be able to encourage yourself as well as your patients to eat, even if they have especially if they have a risk of cancers, and or they've had breast cancer or prostate cancer. So why are they different from the mammalian estrogen? So when we put on weight, we tend to have excess body fat, which traps a lot of mammalian estrogen. So we are producing more estrogen. So that's why we know those who are overweight have higher risk of developing certain hormone-related cancers. The same way, when you intake dairy and meat, you tend to get mammalian estrogens, and they will stimulate prostate. In fact, men who have a regular serving of dairy have a 25% increased risk of aggressive prostate cancer, and men who eat soya regularly have a 25% reduction in prostate cancer. Same thing for breast cancer, but the studies are not as conclusive as prostate. But it's important to know that the plant estrogens or the isoflavones are not the same as the hormone estrogen, and soya foods are not just isoflavones. They have a lot of nutrients, micronutrients, vitamins, protein, fiber, and they don't stimulate the vaginal maturation index. So it's really important to know that they work through the estrogen beta receptor rather than both alpha and beta, and that's why they help to reduce osteoporosis, while they help and reduce and build bone and reduce breast cancer, but actually help to build the breast during puberty, and that is because of this SERM action. And I have a whole chapter on my website as well as in my books trying to explain. I don't get paid by any soya industry. There was a wonderful study done by Neil Barnard from Chicago group. And basically what he did was he subjected women, it was a small study, only about, I think, 64 or 74 women, where they were asked to eat a plant-based diet, but he added in half a cup of mature soybeans. That's about 55 milligrams of isoflavones. I don't eat mature soybeans. They're not so easy to cook. So I tend to have about 3 to 4 portions of soy, which is about 75 milligrams of isoflavone, but 55 milligrams of isoflavone is available from a glass of soy milk and a cup of edamame beans, which are the young soybeans, or half a block or a handful of tofu or tempeh. So when these women ate these foods, they found that moderate to severe hot flashes decreased by 84%. Now, if that was a drug, everybody would be flocking to it. I would not recommend taking soy isoflavones in a tablet. You want to stick to the whole food. And in 12 weeks, they found a reduction by 84% and almost 100% for those with mild hot flashes. They also found that when they cut out barbecued foods or fried foods, so think samosas and fried foods, puris and things, when they reduce the dietary advanced glycation end products, because they are high in these fried foods and ultra processed meats, they found a dramatic reduction in hot flashes as well. So fantastic studies by Hannah and by Neil Barnard that actually helps people who can't take HRT because they have breast cancer and their oncologist is not happy for them to have it, or for anybody who doesn't want to take HRT because not everybody wants to take medications. And start your children early. After the age of 1, after one has stopped nursing, really you should be introducing a portion of soy for the children, for your grandchildren, and for yourself, anywhere between 2 to 4 portions, depending on. I lift a lot of weights, so I tend to have about 4 portions. I'm physically active. I'm usually walking, playing golf for about 4 or 5 hours a day. So it does mean that you want to bring these protein rich foods into your diet. And we know that it helps with weight loss, keeps your heart healthy, bone health. And we found studies have shown that those women who are on tamoxifen, the ones who ate the most soya, had a 38% reduction in dying from breast cancer when it returned. That is massive, and it's important because so many women are scared of taking soy if they have thyroid issues or if they've had a history of cancer. But the British Society now has given its blessing, and it's really quite useful to see that, because we have hundreds and thousands of papers and hundreds of studies confirming how safe soya is at every age, for every age group. And this age-old question that all my meat-eating friends will have, but what about protein? I promise you, when you look at the elephant or the rhino, you're not thinking where they get their protein from. Or if you want to look at like a gazelle or a deer, they also are completely plant-based. So you really want to focus on protein, and you can get your protein from a variety of sources. But you can see that tempeh and tofu are particularly good sources, and textured vegetable proteins, and corn, as well as seitan. Seitan has something like 40 grams of protein every time you eat a small portion of it. And so you can have soya chunks in your curry, you can make tofu palak, you can have all these. I have wonderful recipes on my website that people may be interested, and it's all free. So always focus on color. So this would be a typical way I would tend to eat: a big bowl of porridge. That is a great vehicle for protein powder and flaxseed powder, because that can help to reduce hot flashes. You can have a smoothie at your desk if you're rushing, or if you're somebody with a smaller appetite, or for those who are pregnant or children who can't eat a lot of fiber. So find ways of bringing color in. And remember that you want to eat 10 to 13 portions of fruit and veg. So 5 to 6 fruits and a big salad will cover that. And for a child, the portion is much smaller. It's a size slice of an apple compared to a full apple for us. So don't push your children to eat huge amounts because they have smaller appetites. So you want to make sure that they're getting a range of foods rather than just focusing on a big one fruit, for example. Make water the drink of your choice. And these are great lunches, baking a whole bunch of sweet potatoes and potatoes, taking them to work and putting some chili on it, beans and things like that, maybe some steamed vegetables, or your hospital canteen can do it, even if they are not plant-based friendly. So it's really important to really focus on color, but every portion helps. So for a patient who has never eaten fruits or vegetables, and I get a lot of those, I don't tell them to start eating like this. I tell them to start with maybe a bunch of grapes or maybe some cucumber and slowly build it up. And before you know it, they're running. Okay, probably try and wrap up in 10 minutes. Restorative sleep is the next pillar. So we've talked about food. We want to talk about sleep, and really you're trying to get 7 to 9 hours. Some people can function with less, but you need to find a way of having a good sleep routine so that your melatonin levels start rising. So early morning light is really important. Eating early in the day, minimizing caffeine and alcohol. If I have coffee after 10 o'clock in the morning, I do not get sleep in the night. So different people have different sensitivity, but it's really important that you actually figure out what is the best way, because we know that menopausal symptoms, stress, pain, all these can affect sleep. So you want to prioritize sleep, even though it may feel that, watching TikTok or Instagram is actually much more fun. The next pillar after food and sleep is exercise. Exercise helps in many things, but it does not help you to lose weight. So it's a big myth that has been sold by the gyms. What it can do is help you to maintain your weight loss. You have to exercise for about 4 to 6 hours, like Usain Bolt, to try and lose weight from exercise, but it helps to reduce the risks of cancer, improves quality of life, helps with hormonal balance, improves hot flashes, and also improves mood. How much should you be moving? Ideally, for menopausal women and for people above the age of 50, you really want to be going not with the American guidelines of 30 minutes a day, but really 60 minutes a day. And what is not negotiable is strength training. If there's one takeaway today, I want you to go, or two takeaways. One is bring soya into your diet and into your patient's diet and encourage them to lift weights. It doesn't matter whether they are cans, whether they are weights. If they've never done anything, get them to do it under supervision. If you're particularly small built, then try and get a vest when you walk, or ankle and or wrist weights to improve bone mass, because you don't want the bone to start looking with all these lacunae, which is osteoporosis. And as I said, from the age of 30, the bone loss starts reducing, but starts really accelerating once you hit menopause. And so we want to do things like skipping, jumping, anything that causes micro trauma to the bones will help to promote bone growth, rather than taking osteoporosis medications or calcium, both of which are not really proven on major studies and actually can have negative bone loss when you stop them. And calcium, especially for postmenopausal women, studies have suggested that you might increase your risk of myocardial infarction. So I would rather you got your calcium from food like sesame seeds and green leafy vegetables and oranges and things like that. The next pillar is stress. So we've done nutrition, exercise, sleep, and we are now gone into stress. And so we know that acute stress is great. Coming here can make my heart rate go a bit faster, but what I don't want is chronic stress, because it can worsen insulin resistance, heart disease, both of which plague. More women die of heart disease in the menopause than men. But because we tend to die in our 60s, people don't talk about it. And so it is important to know that the British Heart Foundation now talks a lot about women and heart disease. So find ways of identifying your stress, because all of us will have stress. And while you can't get rid of all stress, find ways of sitting for 5 minutes and doing breath work, or talking to a friend, or getting morning light, or doing yoga or CBT or meditation, exercising, talking to a friend, some way of reducing your stress, because stress is a huge impact which we don't understand, is a silent killer when it comes to cancer risks, as well as menopausal symptoms and high blood pressure, etc. The last pillar is building positive connections. So, really, as I said, try and surround yourself by people who will lift you up and people who can actually help you in times of need, but also have a life purpose, whether it's looking after grandchildren, whether it's, helping in the community, whether it is continuing to work as a doctor. Find a life purpose, because we know that those who do tend to have happier and healthier lives. The last pillar is risky substances. I'm not going to talk a lot, because we all know that the advanced glycation end products from processed foods can increase several risk factors, including menopausal symptoms. There is no safe limit for alcohol. There's no safe limit for eating barbecued meats, and dairy is associated with endometrial and prostate cancer. So we do want to be mindful and trying to swap out for soya milk, not almond milk, not rice milk, because they don't have the same nutrition profile that soya has, which has the same amino acid profile as egg white. Any amount of alcohol is harmful, not just to the brain, but to the whole body. And even having 2 small glasses of alcohol for a menopausal woman will increase her breast cancer risk by about 15%. I'm not sure shall I speak for 5 minutes on HRT, Vidya? Or shall we stop?
That should be fine. Go ahead. No problem.
Okay. So, of course, some women might be doing everything for lifestyle, others cannot do the lifestyle, and they do need to be on hormone replacement. And so I address all these questions in my website, in my book. And the small takeaway is that yes, HRT is safe for the vast majority. How long can it be taken? It can be taken pretty much indefinitely, but we say try and take it for 2 to 5 years around perimenopause and in early menopause. So in your late 40s, early 50s, and try to be done by 60. But if you want to continue it, that's fine. We don't like to start people on HRT for the first time at the age of 60, or if they're 10 years past having stopped their periods. Why? Because we are then not sure what we are treating, and we don't have the studies. Because the WHI study, the Million Women study, looked at 70-year-old women who already actually had a focus of breast cancer. They were trying to see whether women had less a chance of having a hip fracture. And when they found that women were being diagnosed with breast cancer, they stopped the study and said HRT was causing the cancer. And that is wrong information. In fact, we know that women who take estrogen only HRT, if you've had a hysterectomy and you're on estrogen only, your risk of breast cancer actually is lower than the general population. So it's important to know that testosterone, I do have some patients on it, especially for brain fog and those who lift a lot of weights, but testosterone hasn't been studied. And one out of every 10 patients that I may put on testosterone actually stay on it because they can have side effects if they don't use it appropriately, and it's not licensed in the UK at least. Uh, with breast cancer, vaginal estrogen is fine for the vast majority, but I always work with the oncologist before recommending any form of HRT. Or if I have done a hysterectomy for somebody with endometrial cancer, they can be on HRT. But again, all these discussions have to happen side by side with the oncology team, and we have multidisciplinary meetings. So lifestyle changes have to fit in as much as possible because we are going to live the average life expectancies now into our 80s. So we have nearly 3 decades or more when we are going to be menopausal. So we want to bring in diet and lifestyle changes. If you have a uterus, you need estrogen and progesterone. You want to start with the lowest dose when you start HRT. But if you are somebody who's under the age of 40 or 45 and have done a hysterectomy, removed your ovaries, I want to start with quite a high dose and then start tapering it down. You want to be assessed in 3 months to make sure that there's no bleeding, and then yearly after that. And we always prefer the transdermal route. But you have to be willing to look outside the box because some women cannot tolerate or they don't absorb. So black women, for example, cannot, they often find transdermal route doesn't suit them very much. So you've got to think laterally, you've got to try different combinations, but doing levels don't tend to be of much help, and it's clinical symptom relief that you're really looking at. And so you take these clinical decisions. You don't taper it when you want to stop it. You just stop it. Studies have shown that tapering versus stopping that makes no difference. And if you're 10 years more after stopping your periods, or if you're over the age of 60, really that has to be a very calculated decision along with your specialist. So I would sit with somebody to ask and find out why they want to go on HRT. Have they been denied it and they actually have it? Because remember, 10% of women, even after 12 years, most people's hot flushes will stop in 3 to 4 years, but you'll still have 10% still going strong at the age of 60 or 70 where they're still having hot flushes. So they may be candidates sometimes for trying HRT. And estrogen is the most effective way of managing it. It is safe for the vast majority of people. Some women cannot take it because they have a history of stroke or cancer or thrombotic episodes. But it is important to encourage lifestyle measures alongside and instead of HRT, starting as early whenever you see the patient as soon as possible. Some women will find that, because studies have shown that cognitive behavior therapy helps with sleep disturbances, acupuncture can help, hypnosis studies have shown that they've helped for hot flashes. There are some non-hormonal medications, like I talked about, the candy neurons, the NK3 antagonist, Veoza, and antidepressants can help. I don't have a lot of experience in these because most women tend not to need them, but our primary care physicians sometimes use them because they may see these patients a bit more. I really suggest avoiding herbal medications such as soy isoflavones and red clover, black cohosh, unless that is the only method you have, because I would much rather that you ate the food rather than taking something in a tablet form, because it is already not natural anymore and it's not standardized. The same way we don't recommend bioidentical hormones that are custom compounded. We always want the NHS or the FDA approved drugs so that we know what we're getting. A word about supplements. A lot of people will come taking about $150 worth of supplements to my clinic. I would say throw them out. What you need is B12, vitamin D3, check your levels, make sure they're around 75 to 100 or whichever is your local measuring unit. I would recommend taking an algae-derived omega-3, although you can get it in walnuts. I do think that if you're not somebody who eats fish, which is not necessarily necessary in our diets, you want to get in some algae-derived omega-3. In UK, I recommend iodine because our salt is not iodized, and you also don't want to be taking a lot of iodine. But I really recommend avoiding the reductionist approach and eating a varied fiber diet. 1 in 2 of us will get a cancer diagnosis in our lifetime, and 1 in 7 of us will get breast cancer diagnosis, and most of them are not related to HRT. So it's alcohol and weight and environmental factors are much more important, and 25% are actually preventable, which is huge. And we have to remember that lifestyle trumps genetics, and 4 in 10 UK cancers can be prevented. And that is the cancer recommendations by the American Institute of Cancer Research, the same 6 lifestyle pillars that I was talking about. So really, there's no different diet for menopause, for cancer, for aging, for high blood pressure. And with the leading causes of death in the UK, dementia has overtaken all leading causes of death, but it's basically the same, jostling heart disease, cancer, and dementia. So all of these are lifestyle conditions. And so again, finding your group. This is me in my book launch where all my book club friends came up with the book, and we all had this fun a little dance that we did, but really trying to have social interaction, avoiding alcohol, because dementia is known as type 3 diabetes. So it's really one of the things we don't want to spend the last 15 years of our life in a hospice where we don't in a home where we don't recognize our close loved ones. Okay, that's basically the summary where, we've talked about all these details, but really focusing on a low saturated fat diet, high fiber diet, eating soya, and avoiding custom compounded bioidentical hormones, and taking away that HRT is safe, soya is safe, and do strength training for all of us, whether you're a man or a woman. And no, don't need this. So the important thing is it's never too early and it's never too late to make these small changes, and also avail of all the screening things that you can get, the pap smears once in 5 years in the UK, and mammograms once in 3 years. And try and always direct your patients to recognized websites, the Royal College, the British Menopause Society, Mayo Clinic, the NHS. I have to say, I think my website is very evidence-based, so I'm happy to recommend it. It's got 50 different fact sheets, podcasts, and Plant-Based Health Professionals is a wonderful site as well. And these are the 2 books that you can get on Kindle and on Amazon India. So that's me done with there. I think I'm a little bit over time, but shall I stop sharing?
Yeah, you're good. Over to you, Dr. Meera.
Absolutely wonderful. A very comprehensive update about everything we need to know about perimenopause, menopause, how lifestyle fits in, and all the demystifying myths and facts. Thank you very much. We have a question here by Dr. Akila. 36-year-old, 2 sons, Marina, endometrial hyperplasia, BRCA2 positive, much contemplation, total hysterectomy with VSO. Maternal grandmother had CA breast. HRT is recommended. If so, for how long?
So how old is she?
36.
36.
Yeah.
She should be taking at least till the age of menopause. So anybody who has a hysterectomy, say at 36 or 38, there is no reason why they shouldn't. But the age that we say we will review again will be around 51. So until 51, they can close their eyes. They don't increase their risks for anything else. But I'm assuming that this person with endometrial hyperplasia may be carrying some excess weight, may get benefit from diet and lifestyle as well. So I would strongly recommend, because I have seen a lot of my patients reverse their changes. I put a Mirena coil in, and then I've scheduled them for a repeat hysteroscopy and then a total laparoscopic hysterectomy, and I've not had to do it. So there are a lot of situations where, depending on how much of information, how motivated the patient is, we can do it. So a hysterectomy is fine, but there's no reason for her to avoid HRT.
Okay.
Shobana, would you like to have any comments or questions?
So thank you very much, Dr. Nitu. That was a very holistic approach to menopause, advocating for lifestyle and diet, which is often the missed thing in our menopause management. I think we had a few questions which I've answered. I would like to ask, bring in some of the concerns that we have. Can you hear me?
Yes,
Yes,
very
Dr.
well.
I'm sorry for interrupting.
Yeah.
You could take even if you have answered the questions in the chat box, if they're relevant, go ahead and voice them after you finish whatever you want to say. The
Okay.
chat questions are just to provoke discussion. It's not just for Q&A in the chat. Others may miss it because they're listening to you. So sorry for the interruption. Go ahead with your comments and then, yeah.
So, you talked a lot about soy and tofu, but I would like to also bring in the fact, Nitu, that a lot of people, vegetarians here, but still they don't take soy and tofu for lack of awareness mostly. Also, somehow the taste of soy, tofu, mushroom is not very well welcomed by the vegetarians. Of course, it is an acquired taste. So this is somewhere a place where we have a lot of counseling to do because a lot of vegetarians eat a lot of carbohydrates only, and they
Correct.
don't have proteins and vegetables, and they focus a lot on the carbohydrates. So this is one area where soy and tofu may be a very something that is taken for granted in other settings. In our setting, it is not
No,
so,
they're
particularly
not.
lower middle class
It's
population.
the
So that's
same,
something.
the
So the
same.
soy chunk, somebody had asked in the chat box, the meal maker, as it is called, does it have the same nutritive value as the soy bean?
No,
Natural.
obviously not. Anything that is slightly more processed doesn't have the same. But you want a whole repertoire. You want a child or an older person to enjoy a soy, some. Today I made khichdi, for example, and I put, half a tub of soy chunks in it because that increases the protein amount. I don't want to put tofu in that. While I'll make instead of palak paneer, I'll make a palak tofu. So everything has a place. So it's not the same as tofu. Tofu has got more nutritional benefit because it's got all the other nutrients. It's not been that much processed, and soybeans have even more. But there's a place for all these different items. And one thing I'll say, we have the same resistance here as well for soy because people have been told, they see on Instagram that it's carcinogenic, and doctors are telling them that don't have it because we don't know whether it can cause cancer. My advice is, as a doctor, we know that studies have shown if, for example, Vidya is an anesthetist, if she tells her patient, don't smoke, smoking is bad for you, that has more impact than over 5 to 7 counseling sessions. Doctors have a lot of impact. So when you tell your patient, I'm giving you HRT or I'm giving you cancer medication, but also I'm prescribing for you. So it's a prescription, exercise prescription and a diet prescription. I'm telling you to eat 2 portions of soya, a glass of soya milk or soya yogurt, and I'm asking you to eat a handful of tofu. That is my prescription. When you come back to see me in 2 months, tell me whether you've eaten that. Tell me whether you have gone for a walk every day, 5 minutes, then 10 minutes. So these are exercise prescriptions and they're known as fit prescriptions. And so I encourage doctors to start prescribing lifestyle and lifestyle medicine in that fashion so that patients first of all honor it because they love what doctors say, but also it feels much more relevant to them and more scientific and more doable. That's what I would say, rather than, yes, there is a thing, but you tell a patient to eat a mushroom because it will save her life, I promise you they'll run out and buy all the mushrooms.
So, in that regard, there's also another question. While you advocate plant-based diet, tubers, fruits, or something which can increase the risk of NAFLD, a
No,
non-alcoholic fatty, while they think
not really.
anything
When
right.
you
No, I don't think so too.
Yeah,
Yeah.
no.
So, there's
We're
another
talking about the
question
whole
about,
fruit. Shobna, we're talking about the whole fruit. We're not
yeah,
talking about fruit juices.
about
We're not
juices.
talking about anything that will increase the fatty liver. We're talking about fruits with the fiber. So watermelon, not watermelon juice.
Yeah,
Whole
fruit
different.
juices are very popular. Being an obstetrician, I know that every pregnant woman
Yeah.
has a juice. That's another taboo that
No.
another practice that we have,
Yeah,
of late we have started
correct.
discouraging them from doing. There was another question about the primrose oil
Primrose
extract.
oil.
Yeah,
Very popular in this country. Primrose and other forms of natural isoflavones and
yeah.
things like that. People are taking them on a long-term basis, like years
Correct.
together. And we would like to have your opinion
So
on that.
evening primrose oil is very popular for breast pain, just like starflower oil. But the if you look at the studies, there are no randomized trials, and I always tell people you can take it for 2 months. If you don't see an improvement, it's very unlikely you're going to find an improvement. But when people take, there are a lot of medications here that have got evening primrose oil, they've got soy isoflavones. I'm always very wary of something that has been put into a capsule. I'd much rather it was then checked by the pharmaceutical industry and properly standardized rather than having, I'd rather somebody had the herb rather than a herbal tablet, because I just feel that these things have been processed so much we don't actually know what is in it. So evening primrose oil is good for some people. It does help them with breast pain leading up to the period, but usually if it hasn't helped in 2 months, they're wasting their money.
So the other thing that I wanted to bring up is a lot of our women have an early menopause, not
Yes,
strictly premature ovarian insufficiency, between 40 and 45.
early
And
men. Yeah.
our women have more of musculoskeletal symptoms than
Yes,
the middle flushes. Probably they're not
yes,
aware and they're not bringing it up, but still we find very high proportion of musculoskeletal symptoms. So our approach and our quest for finding out whether they're having symptoms also have to be a little
yes.
customized to our population.
Absolutely. Absolutely. If you look, actually, in my book, there's a whole chapter looking at the different. When I come to India, if you don't get it on Amazon, when I come to India, I'll make sure that I post it to all of you. But I have a whole chapter where I'm looking at the different groups. And we know that, say, women, there was a nice study from Delhi where they saw that women actually don't complain of hot flushes. What they complain are joint aches, arthritis, musculoskeletal symptoms. And so, in this situation, this is where strength training, because the most sedentary group of women in the UK are actually Asian women. So we know that that is translated even back home. And so we want people to move because there's this reluctance to go to the gym or go for a walk. They have to cook 3 meals in a day, so they're always tied to doing something. So encouraging women not to be conscious of their body shape and actually, looking at YouTube, there are so many classes that people can do now, yoga, Pilates, weights. These are really important. That will help to reduce musculoskeletal symptoms. And this is where the green leafy vegetables, the soya, the beans, and prunes, dried plums, even 2 prunes a day have been shown to reduce the risk of osteoporosis and muscle ache. So we want to bring in these things because when you increase the energy levels by eating less processed foods and more raw and whole foods, women themselves will start saying, oh, my body doesn't ache so much. But it's a process of education. And so that's where what we're trying to do is educate the public, educate the doctors, because women now are very smart. They want to take life, they go to their doctor. So I say, go to your doctor, give them the book. I will give them a free copy. Give it to them because they need to be educated so they can treat you, because I don't want to see every patient. I can't see all my patients all over the world. I don't see patients from abroad. I want people to know that there is so much help available, and with musculoskeletal symptoms, instead of being put on medications, because that's what happens, they get put on medications. We don't want medications. We want to try first diet and lifestyle rather than being on constant ibuprofen or brufen, and they're not able to move their bodies.
There's another question. Um, do soy products have an effect on the breast growth or ER positive cancer?
No.
No. Yeah.
Soy is safe, and they can go on to the UK Society, the Cancer Research UK, which is now given, because I know this because I was in the middle of a big storm when there is a lot of groups who are anti-soy, you see, and they tend to be the dairy industry because they don't want soy to come in. And so, it's very complicated, isn't it? The junk food industry, the animal industry, they're all very intertwined with the politicians.
What to do for burning sensation at feet? It started at 45, underwent hysterectomy at 50. Burning sensation continues in the feet, especially at night. It's worse.
I would check my B12 levels.
Exactly.
I would check my vitamin D, and I would strongly, strongly consider HRT, estrogen only HRT in the form of a patch or a gel. Life will be usually transformed for these women. And it's a shame that, if they don't have access to that.
What's late menopause? Does it put women at risk for breast and uterine cancer?
Sorry, what's the question? What was it? Did I
Late
miss?
menopause, does it? What is
Well,
late menopause?
yes, to some extent, but there's little you can do if you're somebody who's destined. I've had two patients in my 44 years who have had menopause. One has had menopause at 60, another one at 61. You're really unfortunate, but the range is 45 to 55. And if it's beyond 55, you have to ask yourself, is that, do you have other lifestyle factors? Are you carrying excess weight? Do you smoke? Do you drink? Which may not apply to India, but diet and sedentary behavior can be increased, and those we know increase the risk of uterine cancer and things.
And if they have severe osteoporosis, can MHT be combined with bisphosphonates or teriparatide?
Yes, but actually, you may not even need the
You don't need.
bisphosphonates because we know
Yeah.
bisphosphonates can actually leach the bone even more. I would say at some point, Vidya, maybe you can ask Rajiv to do a talk on bone health. He's got a wonderful talk on back pain and on bone health. He's a spinal surgeon. And I think it's important to realize that even if you have osteoporosis, osteopenia is different, but even if you have osteoporosis, under supervision, you can start exercises and you can actually build bone nicely along with the diet side of things and making sure that your vitamin D and the other micronutrients are covered. So I would be a little bit hesitant before just prescribing bisphosphonates. I would really sit the patient down and look at the whole system. But yes, there's a whole talk on this and there's a whole chapter on this.
Right
What
at the
about
beginning,
single
Ravi had
oil?
asked,
So the question was about, can you take HRT and bisphosphonates? Usually HRT on its own along with strength training would be enough. But yeah, you can add these medications if you feel, your doctor is not willing to prescribe anything else. Sorry, Vidya.
no, I was just saying that right at the beginning, Ravi had asked, what's the mechanism for differential symptoms? Why some have very bad hot flushes and others have none? Like, for example,
Yeah.
is there any?
So if you look at the even the racial distribution, you look at Mayan women or Japanese women. Japanese women have hardly any symptoms. Why do we think that? Because of the high intake of soya and plant-based foods. Why do the African community have such severe hot flashes in the US? We think it's to do with socio-economic factors, with historical oppression, as well as carrying excess weight and eating a lot of saturated fats that have been subsidized by the government. So we know that it could be lifestyle, it could be stress factors, it could be epigenetics because of all the trauma that one has gone through over centuries. So it's very complicated, but in an individual family as well. And also many women don't talk about it. They haven't had the place to talk about their symptoms because they've been told that everybody is more important, and we tend to come below the dog. So what tends to happen is you want to make sure that our voices are heard, women's voices are heard. And so I'm not so sure that people don't have any symptoms. I think people do have symptoms in a different range, but how you are, how privileged you are with lifestyle, diet, access to good food, access to exercise, access to education, all these things will inform how you experience menopause, because there's social factors, cultural factors, genetic factors.
So you've
I hope
already talked
Ravi, I
about,
hope Ravi that has answered your question.
yeah, you already talked about this, but nevertheless, one more time we'll go at it. What's the
Yeah.
explanation for the results of HERS? Even now in the US, HRT is not freely prescribed, especially in women with coronary artery disease or a strong family history of coronary artery disease or cancer.
Yeah, I think if you have a personal history of coronary artery disease, I think most people will be very hesitant because first you have to make sure the estrogen, the cholesterol is normalized, the body weight is normalized, but there is a place. But all these have to be with specialists. They cannot be a primary care physician decision.
So the Rohini said,
Family history on its own is not a contraindication, whether it's breast cancer, any of that. But as I said, whether you take Wegovy or Munjaro for weight loss, whether you take HRT, diet and lifestyle has to be spoken in the same breath. People have to do that.
I think
Rohini was
there has to be a very individualistic approach to this HRT prescription, taking into account their risks, and risk assessment has to be done.
Yeah.
Just like now for oral contraception, WHO has come up with a medical eligibility criteria, and several professional bodies have done that as well. For HRT also, I think, but these are all like slightly complex issues. Somebody with a breast cancer, BRCA antigen
Has to
positive.
be individualized.
Yeah, individualized. Yeah. There
And also
is
the
no
patient's
absolute
wishes.
no.
Yeah,
Yeah.
Shobna, also the patient's wishes. It's so important because, if you don't have the person on board, they're not going to follow whatever instructions you tell them. So, denying somebody doesn't help because these are intelligent people who can take risks if their quality of life is so impacted. And as doctors, we have to respect that. We shouldn't be so worried, oh, we've prescribed something that we can't stand by because as I said, women do know their mind and they do their own research and come to us. And then when they do, as long as they're willing to accept some risks, we have to be willing to talk to them and involve other physicians as well. Sometimes you have a group discussion. MDT discussion makes such a difference because there's a lot of power in that in a group decision.
So Rohini had a comment that you mentioned ghee, but recent studies have shown that good health benefits if consumed in moderation.
So I would say ghee would be okay for your great grandmother who didn't have access to other good foods. But ghee, if you want to put a couple of drops on a roti, that's absolutely fine. But having a ghee in a tablespoon is just saturated fat, is pure saturated fat without anything. Good studies have shown how they increase the risk of heart disease, and I would strongly recommend against. So it's like extra virgin. If you're going to choose something, use cold pressed coconut oil if you want to. But coconut oil is in the same group as ghee. They are saturated fat and they're best used as flavorings rather than cooking and deep frying in them or using them in huge amounts. I always suggest use salt, sugar, oils, except if somebody is trying to put on weight or a child, then use the extra virgin olive oils and the avocado oils and those cold pressed oils raw because that has got many health benefits as well. But if you're trying to lose weight, which is 70% of the population, 1 tablespoon of oil itself, forget ghee, 1 tablespoon of oil is 120 calories. For that, you can have a nice bowl of khichdi for 120 calories. I know what I would choose in that situation if I was trying to lose weight.
So, Dr. Venkatesh, you have an important point. So, would you like to unmute and speak?
Yes, ma'am.
Yeah.
My question is most of this customization of diet, especially there are a lot of. I was part of a study which we looked at menopausal symptoms in women in Puducherry. So the burden of symptoms are quite enormous. If you go back and look for it, definitely you're able to find that plenty of women, especially the working class women, they suffer from it. And one of the problems that we had is in customizing a diet regarding this. I would like to know Dr. Nitu's opinion on this because access to certain types of food is not very easy, and we had a tough time trying to figure out what would be the appropriate diet for them.
So,
If you can kind of enlighten us
yeah.
on that, that will be great.
So
He's
we
talking
have a
about
lot of
lower
people.
socioeconomic status. Nitu, he
Yeah.
wants you to focus on lower socioeconomic
Yeah,
status.
so I have a lot of people who are from the socioeconomic status. So I run a class where I teach people cooking. And so one of the things we always suggest is always shopping late at night or when something is on sale. So we know that when you go to the shops or the supermarkets, when things are towards the end of the day, the sabji wala wants to get rid of his stuff, the shops want to get rid of their beans and things that are actually going off date. So same thing I would apply to customization of diets in India, where I tell people to focus on foods that they find they can get at a cheaper cost. So that group of people are not going to be able to eat your tofu. They cannot eat your the tempeh and the soya beans because they cannot afford it because they have not been subsidized enough. So I would ask those people to find ways where they can increase their intake of beans and dalia and sattu. These are things that are high protein. So there, a lot of flours in India, the dosas and all, instead of making it with white rice, they can make it with red boiled rice. So small changes will increase their fiber intake, their protein intake, and as a result, their menopausal symptoms will improve, because a lot of them will end up spending 5 rupees, 10 rupees on a packet of kurkure or a samosa, when you teach them actually these are not going to bring you health. If you want to feed your family a bunch of bananas, for example, try to find ways of buying these foods when they are almost going off the shelf. So whether it is the thela gadi wala who's coming towards the end of the day, and this is what I do when I go to India, when I've been walking around Bangalore and Bombay and teaching groups. That's what we do. We try and actually teach them how to shop intelligently, and how to avoid wastage, and to improve those foods that I talked about. There's a huge range. So buying herbs and spices can be expensive if you go for the organic versions, or if you try and buy organic food. I'm not a fan of organic food. I always think you should buy what is seasonal, what is local, they'll be cheaper. So teaching lower socioeconomic status people as well, and this is the same truth I know, because I've been working with people who come to people's houses, and so I've been working with those groups in Bangalore. So I think it is possible, but it needs dedication, it needs time from a group, and usually just a physician alone is not enough. You need a team around you, and that's what I have tried to do by building it here for my Women for Women's Health. But it does take a lot of effort.
Thank you, ma'am. What about fishes? Because these communities prefer
Yeah,
to eat
yeah, of
fish.
course. So, while people like you and me who come from a socioeconomic status where we don't need to worry about we need to worry about climate change, we need to worry about what is in the fish with the mercury and the pollution and things like that. So, I always recommend eat small fish. If you're going to eat fish, eat the fish that you see all the Mumbai women carrying on their heads, those little fish in this country, anchovies and things like that. Why? Because they are ground feeders. So they tend to have the least amount of chemical buildup. So when you eat larger things like cows, when you eat beef and lamb and goat and chicken, or big tuna and salmon, they have got bioaccumulation of pesticides and inorganic materials and BFPs and all kinds of things that are there. So I would say, yes, fish is great. Eggs are great for people who are really struggling to find protein in their regular diet. So if they can afford it and they can find it, of course, we're not trying to change those aspects. We're just trying to not think of what you're cutting out. I want people to always think what you're bringing in, because there's a great joy and there's no deprivation in this way of eating. In fact, there is joyous way of eating. So instead of thinking what you're cutting out, tell your patients, let us see what you can bring in. Can you bring water in instead of that fruit juice? Unless it's like fresh sugarcane juice and they want to have it on a hot day, and they can afford it and they don't get cholera from it, great. But otherwise, I will always suggest to people, think of what you can bring in. What can you feed yourself? And a lot of women also, Venkatesh, don't prioritize themselves. They keep for their children, they keep for their husband, okay, rather than for themselves. And we have to change the mindset for that as well, so that they also have to make sure they get a proportion. And I always tell my patients, and I would want all of you to tell your patients, talk to yourself like you would talk to your most loved one. Women are always, and men as well nowadays, are talk to themselves as if we judge ourselves, we are not kind to ourselves, we are very harsh on ourselves. So before we start berating ourselves, oh, we're not good enough, we're not thin enough, we're not educated enough, we're not achieving enough, always think, would I say that to my sister or my friend or my daughter? And actually you will find that it's a much happier life then.
Thank you.
Very nicely put, Neetu. Very nice.
Thank you.
There's a question on whey protein. Here it is a
No,
huge
no,
market, huge business. So,
no. No. Why? Whey protein is dairy protein. You don't want the only dairy that if you're going to eat dairy, have a little bit of yogurt. Okay? I don't, whey protein, instead of that, actually, there's a very good company in India. I can't remember the name. I'm not paid by them. Cosmics, I think, but I'm not sure. But basically, I want people to focus. If you are somebody who's looking at your protein intake, I would suggest trying pea protein, soy protein, rice protein. rotate these or use a combination of it and creatine. We haven't talked about creatine. Those talks are all big. Like a whole nutrition talk would be like 2 hours. But creatine is really important for women, especially those and for men. And you want to have about 5 grams per day. So all those are available now in India. But you don't want whey protein.
So
No.
Venkatesh also asked if CKD patients can take hormone replacement.
MHT.
Is transdermal better than systemic in general?
Transdermal is the method of choice. So, but there are some women who cannot absorb properly, who cannot take it properly. In those situations, you can give orally, but generally, or an implant. But generally speaking, the vast majority, and the major studies have shown the risk of breast cancer and clots and stroke and all are really negligible on transdermal. So usually my patients will be either on a gel plus a micronized progesterone orally, or they will be on a patch, or they will be on a patch or gel and the Mirena coil if they have adenomyosis, fibroids, endometriosis, or they need contraception as well. So everything has to be individualized, like Shobna was saying. We want to individualize every treatment, even though we may have, big sweeping statements as well. We do have to individualize it. But yes,
There's another
transdermal.
question on
Yeah.
Tibolone, Olivia. Is it
Yeah,
safe?
Tibolone. Yeah, I didn't mention it was in my slide. So Tibolone has got this three pathway. It sort of the metabolites are estrogen, progesterone, and testosterone. So it can help with things like libido and brain fog, and it's got a lower risk of breast cancer, maybe slightly increased risk of stroke. But the truth is, I've had many patients in the past. Now I probably have, for every 1,000 women, I'll probably have one woman on Tibolone. Most of them will be either on the progesterone containing coil if they have, because there's a huge increase with adenomyosis and endometriosis and things like that. So HRT can become very erratic when you have these medical conditions, and so they then start bleeding erratically and they don't want a hysterectomy. So I would usually put the Mirena coil, and they have the gel, or they have the patch, or the oral tablet. So again, I've gone into great detail, Mira, both on my website, which is completely free for anybody who wants to forward it to their relatives, their patients. It's just nitubajekal.com. You don't even, if you're not a reader, you don't even have to read the book. My podcast will tell, I discuss all these things in quite a lot of detail. And people can always message me directly, We are all, I'm sure if you send any questions to Vidya, she will forward them to me.
Nitu, maybe you can just type out the website and
Yeah.
thing on the chat box. So, Ravi, you have your hand up. You want to say something?
Yes, I was going to ask if there's any particular preference for the type of estrogen that is used in postmenopausal HRT, like, for example, conjugated equine estrogens or 17 beta estradiol are more selective for the alpha subtype of the estrogen receptor, which is more expressed on vessels,
So we want
right?
to
So
use,
based on,
yeah, we
sorry,
want
go
to use
ahead.
17 beta estradiol always. We
Mm-hmm.
don't want to use the equine estrogens. Estrone is what is produced in postmenopausal women. That's very weak. Estriol is what's produced by pregnant women. That's good. But again, so estradiol is what we want to mimic the natural estrogen of women's bodies. Same thing with micronized progesterone rather than a synthetic progesterone as far as possible. So, but we do use synthetic progesterone in the progesterone containing intrauterine system as well as in the patch. But these have been shown to be safe in those doses. So really, we have a huge range to try. But the other thing we never talked about is vaginal estrogen. Vaginal estrogen is a life changer for women when they are struggling with painful sex, cystitis, and dry vagina. So, and even breast cancer patients are almost always allowed to use local vaginal estrogen, and you use it twice a week, vaginal estrogen cream, and you can use it till you're 110. So there is no time limit, and it's really fine. So it's really, so this week I saw my 96-year-old patient. She has a 75-year-old husband, and it is so lovely to see her. And she is thriving on vaginal estrogen because she can't be bothered with HRT, although I do have 90-year-olds who still want to take HRT. And then I have 40-year-olds who are really scared of hormone replacement. So you have a whole range of people and you have to respect that. But it should come from a place of informed choice, not what we as doctors choose to inform them, but give them all the information so they can then make that decision. And we are their guides. We are trying to help them navigate it rather than taking their decisions for them. And I think we underestimate how smart people are.
No, agree. I just had a quick follow-up
Yeah,
question to that. So when
yeah.
people go on HRT with estrogen and micronized progesterone, does that mean that these women continue to have periods?
So if you're above the age of 53, usually, or if your periods have stopped for more than a year, year and a half, then you choose the no bleed versions. So you will use micronized progesterone 100 milligram every night. So you get good sleep, you take that orally, and you have the estrogen. If you've had a hysterectomy, you just need estrogen. You might add some testosterone if you are wanting to lift weights and brain fog and things like that. But for the women who are, say, 45, 46, the Indian women who are 42, 45, 48, they will still have periods. So you want to put them either on the sequential patch or you want to put them on micronized progesterone, 200 milligrams, 12 days of each month, so that they will actually have a bleed. But even better, who wants to have a bleed, right? Nobody wants a period. So those are women who would do very well with a progesterone containing coil. So especially if they have background conditions like adenomyosis, which is internal endometriosis, or they have fibroids, or they have erratic bleeding. You don't want to make them bleed and then they come off HRT. Remember that for every 10 women, even in the UK, who start HRT, only one continues on them, because there's so much of misinformation, and also the side effects. They are so scared because they see bleeding because the doctor hasn't explained that actually it's quite common and they haven't given them the right preparation. So then they end up going to a lot of quacks in central London where they have these bioidentical Nitu Bajekal's custom compounded HRT. I would become a millionaire if I sold that. But the truth is, one day you'll get high levels of estrogen, second
That's
day you'll
it.
have low levels of estrogen. And so that I have patients regularly coming with hyperplasia, endometrial cancer, because they're having unopposed estrogen for a long time. You know, as I said, we haven't done that. There's a whole talk on just doing HRT, and there's so many topics. So I've tried to, I think there's a segment in my book which has got whole section on HRT, which is all the common questions that doctors and patients ask, because there is so many doubts that people have before they start. They always feel nervous because that historical being told, what I was told, you can't have HRT because you'll get breast cancer, when I was desperately in need of it at 38, and I couldn't get it because I was too shy to ask, because I was a robotic surgeon, I was a laparoscopic surgeon. I didn't want the men to think that I needed my patch. So I wanted to be, I was an immigrant, I was a woman, I was a woman of color. I needed to not also be a menopausal woman. So I went to my GP, and my GP did not prescribe me HRT. And that was one of the biggest disservices for me, because I have a strong family history of heart disease and things. So, well, I'm still standing here at 63 with good bones of a 25-year-old. So I must be doing something right.
Yeah. That's very important. We talk about cancer risk and breast cancer risk so much. It is to be understood that people, whoever are at risk of breast cancer, are at
Yeah,
higher risk of cardiovascular. And
correct.
women and cardiovascular disease are never getting the same attention as men do.
No.
So it's very, very important for our women, especially because I'm seeing a lot more younger
Yeah,
patients coming with MI
yeah.
and needing CABG because of their poorer thin arteries.
The
So
conversation has started, and it's so lovely to see men in the audience. I've had so many men read the books, and it's so heartening because you have a sister, a mother, a partner, a daughter. It's so important that you actually understand what's going through 50% of the population,
maybe they're
or
looking to you to have solutions for the mood swings they'll have to face. Maybe they're not
yeah,
just
well,
No,
telling.
but can I
and the
can I tell
men,
you something? You're talking about disparities in research, right? In cardiovascular research.
yeah,
The one area where there's more research in women than in men is andropause. there's about 1,000 times more talk and discussion and research on menopause than it is on andropause. And as the population is aging,
Yes,
there is a huge number
I
of
agree.
men who have andropause who don't talk about it because of the stigma associated with it. And it leads to a lot of excess
Totally.
cardiovascular disease.
And mood
Yeah.
changes. Don't forget that,
Yeah.
testosterone is a mood elevator. And if you look at, I play golf now, and I see the young men, and I see Rajiv, and Rajiv will not be able to drive. He might drive more than me, but he can't drive more than the young 20-year-old or my son-in-law, for example. And that's to do with the reduction in testosterone. A lot of men's symptoms are not talked about. I agree with that. But historically, what's happened is obs and gynae and the medical community has been male dominated. So as a result, women have not had a chance to talk a lot. That does not mean men should not be given a place as well. And I think, andropause as well as even mood change, like suicide used to be the most common for women in the past in the UK. Now, 6 times higher incidence in men because women have found work has been done for women. Women know how to talk, women know how to seek help. And now men in rugby clubs, in police stations, because we know that men are such high risk of taking their own lives and nobody actually discusses it because men have a habit of talking about everything except their feelings. And that's because we as mothers, as society, have always said, stop being a girl, don't cry, when actually it is so lovely to see men cry and actually have emotions and that's what we need to be encouraging. So I'm really happy. I love the fact that this group has got so many people who are, actively getting involved in discussion. So it's making me very happy. I might miss my movie premiere though.
Radhakrishna, since Nitu has to go for a movie premiere, time for you to come in.
Well, obviously, very, very typical of Nitu Bajekal is a wonderful lecture, but it's like a deja vu for me. Nitu, my wife is a breast cancer surgeon and she talks all the time about exercise, diet, and all that. I'm scared to face her. I don't know. See, the takeaway things for me is this fit prescription. That's a very nice thing you
Yes.
said. Diet prescription, which as a surgeon, I generally don't tend to do. When they talk about diet, I said dietitian. Whether the dietitian understands the way you understood nutrition, I do not know. I should admit that tempeh tastes terrible. Whichever
If you
way
come
you
to
cook
my
it.
house, why don't you come to my house? I'll make you the. Rajiv is one of the world's best cooks now since COVID. I've handed the kitchen over to him. He should come, do a talk on bone health, and then let him come into the kitchen and you can follow him with the camera and he will make the
I
most
will.
amazing tempeh dish. I promise you. So
And
be in touch with him.
whichever way you do it, even you put tempeh and sambar, it is
You
terrible.
will like
Anyway,
it.
I should see same thing with soya. Soya is again the milk tastes terrible, and soya the Chinese thing. I always consider it a Chinese food, and then somehow it doesn't fit into our Indian diet. You can't make dosa out of it. You can't make idli out of it. You
Everything you
can't make
can make. My sister makes dosa with putting a whole. My mother became vegan in the 1990s. She made her own soya milk. She also made all the idli, dosa, the sambars, the curries with the mature soya beans with the soya. She would squeeze it out, and also you can the soya flour. You can take the soya beans, go to your chakki, get the soya flour, put it into your uttapam, what do you call gun pangre? Appe. I don't know. I was making up. What is
appam.
not appam? Those little round.
Puri paniyaram.
What is?
Paniyaram.
No, no.
Puri paniara.
We call it
Puri
in
paniyaram.
Kannada.
Yeah, kuriappam.
Correct.
Puri
Yeah.
paniyaram.
Correct. We call it gunpangre in this thing. What I'm
And
saying
also,
is you can put soya into everything,
Yes.
and I promise you can like it. Please go onto my website. I have at least 2 or 3
I'll,
different recipes.
I'll do it, Neetu. The
Try
only
the
thing
egg
I
scramble. Try
uh,
the egg scramble.
how do you put soya in egg scramble?
It's called tofu scramble.
Oh, see, even tofu tastes good undoubtedly, but my cook says, "Sir, ye kyun le aa rahe? Bring paneer."
हाँ से क्योंकि
Eating,
मेरे को जिंदा रहना है, मेरे को हार्ट डिसीज नहीं चाहिए, तो इसीलिए मैं टोफू ला रहा हूँ, ताकि मेरे को प्रोस्टेट कैंसर नहीं हो और ताकि मेरे को हार्ट डिजीज नहीं हो। और हम
and
आपको सिखाएंगे, ये जरा नीतू मैडम के वेबसाइट पे जाइए और वो रेसिपी यूज कीजिए।
wonderful. I'll tell him that, and I'll ask him to look up your website and do something about it. Because in India everybody wants to eat paneer. Paneer gives protein, and soya is not so much.
It's just misinformation. And as I said, you don't have to stop eating paneer when you go for a wedding. I'm asking you is don't think about what you're cutting out. Don't say, oh God, Neetu has told this talk, so now I'm not going to eat this. No. The question is, the more you bring foods in, you will crowd the others out. So when you bring fruits in, you will crowd the fruit juices out. When you bring the vegetables in, you will crowd the rubbish that we eat all the time out. That is in eating before you go to the club. Little things like that can have a nice salad, a nice kosamri. There are so many recipes. Really, there is no dearth of. I mean, Indian food is wonderful and it's such a wide range. It's just learning to go back to those roots and eating properly rather than having this idea that one has to eat protein in a certain fashion. We never had to do that. You just have to focus on the right types of protein.
And my last question, Neetu, is that how will I know that when my wife is unpleasant towards me, she's often actually, is due to menopausal symptoms and not something else? And how
Usually
to
it
deal
won't
with
be
it?
menopause. It won't be menopausal symptoms. Usually it'll be something that you have done. You have either breathed around her, you have opened your mouth, and so as a
It-
result,
it- it- I'm no more your
just by
classmate, Neetu. You
existing,
can't take that liberty.
just by existing, it's enough. Rajiv and I have been together 44 years. I love him like to death. But sometimes if I just look at him, I get irritated when he does a bad golf drive. I mean, when we are in a competition, I want him to win. So, you can't change all that. That's not nothing to do with menopause. That is just your
But
relationship
how will
together.
I make out that something is related to menopause in her?
She will make it out herself. You go and read all the symptoms of menopause, you will know that.
So we have Padma on the line. Padma, iPhone.
Yeah. I'm enjoying Neetu's talk and way of expressing things. Express it,
Oh,
and I
hi, Padma.
enjoyed
I
it.
just saw you.
You
Oh my God, you
recognize
look
me?
as cute as ever. Did you have a question or you were just saying hello to me?
Yeah, I'm also a gynecologist. I was enjoying you are wording my words. Yeah, I
Thank you.
do. I do follow you.
Thank you.
Well
Yeah,
put up.
for those who
But
are
your
interested,
diet explanation is little difficult to follow as our other seniors told. No? Tofu and all, we don't get it so
don't have to, but
easily.
don't focus only on tofu. You
Yeah,
focus
yeah.
on tofu for yourself.
Yeah.
Don't focus on the patients. Once you start eating it, you will realize the joys of eating. This is what I find with all my patients, all the people in India that I have now worked. I go because I used to go, every 2 months I used to be in India when my parents were there. So I used to teach and lecture about 6 times a year there. Now I go once or twice a year. But if you bring those changes in, we know studies have shown that a doctor who's overweight is less likely to tell a patient to lose weight or to exercise. A doctor who smokes is less likely to tell their patient to stop smoking. A doctor who drinks alcohol is less likely to tell their patient to give up alcohol. The same way, if you start doing certain things for yourself, you will see the benefits. When you start lifting weights, then you will talk to your patients, say, you don't even have to talk to them lots. Give them a website, give them my website. They want to see me, but they can read it for free. And that allows them in their own time to say, oh, I can do that bit. I can go walking once a day, or I can have a glass of soya milk, or I can eat 5 fruits in a day. I can start my day with a nice papaya and mango and grapes and all that, whatever they will make the decision, Padma. You don't have to take the decision. You just have to point them in the right direction. The main problem is
Yeah.
our patients don't have that ability.
Yeah, have the
They don't
education.
know.
Yeah.
Yes,
Yeah.
you have to point them.
Doctors don't talk about diet.
Yeah,
There should
because
be a
we have not been
prescription.
taught about it.
The
We're not
best
taught
part
it.
of the talk was prescription about diet and exercise.
Good.
I like
Thank
those
you.
two words.
Thank you.
Your closing comments, Dr. Meera.
She's gone. She's got bored, Vidya.
No. There. Shobana, would you like to give your closing
Yeah.
comments? We are ready
Yeah.
to. close. Yeah.
I think the fundamental problem here is there is a lot of contradiction between what doctors say and what the media says, what the books say. And doctors ourselves don't have a very clear idea about the safety and efficacy of HRT when it comes to menopausal hormone therapy. I think we need to be united, we need to be aware, we need to be updated about the evidence for us to say, for us to advocate the role of menopausal hormone replacement. And about lifestyle, you were very correct in saying unless we make that change in our own lives and we are convinced, we cannot convince. And there are a lot of things about the technique of introducing this diet and exercise, because the common problem that we face is they start off but they are not able to continue, they're all giving up very easily, and
Yeah.
therefore we have to have some strategies as to sending in videos, following them up, sending messages and telephone calls. These are the things that we have made in our practice that have made some changes. So I
And
just
also
want
telling them to be not judgmental for themselves. You know, what happens is it's a process. Suddenly, if you go 100% into anything, you will almost always fail. So it's very important to take baby steps. You're not going to run a marathon without running 100 meters, right? The
very
same way with diet, you also have to take those small steps first. You know, as I said, one fruit at a time, one vegetable at a time, one piece of tofu at a time. That's how you increase awareness and sustainability. You can't be consistent otherwise. Because if you tell somebody to suddenly run a marathon or bench press 150 kilos, not possible. But you can start doing it slowly. So that is the message that you give your patients so that they don't feel overwhelmed. Otherwise, information can be very overwhelming. And that's why they have to have the information in their own time in bite-sized chunks. And that's important to do rather than spending lots of time. And, you know, after 45 minutes, everybody will switch off. And, you know, you'll be thinking about the golgappas that you're going to eat after you finish with this talk. So,
Dr. Meera, are you back? Ready for your closing comments? No, in which case, over to you, Nitu. Sorry,
thank you so much, Vidya, for thinking. Thank you so much for thinking of me. And it's really been because I do a lot of these, but I have to say this has been one of the most enjoyable, and just seeing all these beloved faces that I haven't seen for a long time is just filled my heart. I'm so grateful and so feeling so blessed.
Thank you. Thank you. I'm
Thank you for
a lot
inviting
of
me.
first timers who have joined in. Normally, Marvelous Medicine has got a kind of a set following, but this topic has brought in a lot of people who have never been on Marvelous Medicine before. So,
Thank you.
thank you so much. And we'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.